Hi everyone, and welcome to our TED Talk on cystic fibrosis. You will be hearing about the pathophysiology, the different nursing care plans, and the effect that cystic fibrosis can have on a patient and their family. So what is cystic fibrosis? Cystic fibrosis is caused by the mutation of the cystic fibrosis transmembrane conductase regulator gene, also known as the CFTR gene, which is the channel responsible for transporting chloride and sodium across the membrane. This mutation causes a defect in the exocrine gland, and due to this defect, there is an excessive amount of abnormally thick, sticky secretions that obstruct these glands. So what causes cystic fibrosis and what are the risk factors? Cystic fibrosis is an autosomal recessive disorder caused by inheriting two recessive genes from your parents. This means that both parents must be carriers of this recessive genetic mutation located on the 7th chromosome to pass it on to their children. There is a 1 in 4 chance of inheriting two recessive cystic fibrosis mutations. In Canada, 1 in 3,600 people born will be diagnosed with cystic fibrosis. The disorder is commonly diagnosed among Caucasian people, specifically Northern Europeans, where many of the populations are asymptomatic. If there is a family history of cystic fibrosis, prenatal testing is available and should be offered. So how does cystic fibrosis affect the body? Well, the sticky mucus obstructs passages in many areas of the body, affecting many organs. Let's start with the lungs. The thick mucus causes airflow to be obstructed in the bronchioles and the small bronchi. This causes air trapping or atelectasis, which can cause permanent damage to the walls of the bronchi. Since this mucus is stagnant or not moving, it fosters an environment for bacteria such as P. aeruginosa or Staphylococcus aureus to grow. This is why many people with cystic fibrosis suffer from chronic lung infections, further damaging the lung tissue. As the fibrosis or thickening and obstructions advance, bronchiectasis or permanent dilation can cause symptoms such as a chronic cough or mucus production, and emphysematous changes, which is damage to the alveoli, will occur. As cystic fibrosis progresses further, respiratory failure or cor pulmonale, which is right-sided congestive heart failure, may develop. Next, we'll discuss how CF affects the pancreas. The thick mucus blocks the exocrine gland of the pancreas, leading to a lack of pancreatic digestive enzymes in the intestine. The CFTR channel plays a role in producing an alkaline isotonic fluid when food is digested. This fluid helps move digestive proenzymes from the ductal tree of the pancreas into the duodenum to neutralize the acidic chyme when it enters the proximal part of the small intestine. Without this, the client will experience malabsorption and malnutrition. Additionally, if the mucus is obstructing the gland, it will eventually damage the cells of the pancreas, including the islets of Langerhans, which are responsible for insulin production, which can cause diabetes mellitus. Next are the bile ducts of the liver. Since the mucus is also blocking the bile duct, bile is unable to enter the duodenum, thus interfering with the digestion and absorption of fats and fat-soluble vitamins. This causes further malabsorption, malnutrition, and dehydration. If the duct is severely obstructed, the bile can cause inflammation and damage to the liver, causing biliary cirrhosis. The thick mucus also has an effect on a client's reproductive system. This is caused by the vas deferens in males and the cervix in females being obstructed with thick secretions. This can unfortunately cause infertility in both genders. With regards to the clinical manifestations, often the first sign is a meconium ileus at birth. This is due to a mucus obstructing the small intestine, preventing the baby from passing meconium in the first 24 hours. So other symptoms include salty skin, bulky, fatty, foul-smelling stools due to the inability to digest fats, abdominal distension, failure to thrive due to the lack of pancreatic enzymes necessary to absorb nutrients, and respiratory problems such as a chronic cough, respiratory infections, hypoxia, fatigue, exercise intolerance, wheezing, shortness of breath, rhonchi sounds upon auscultation, and there is a potential that growth milestones will not be met due to chronic respiratory. So how is cystic fibrosis diagnosed? The initial diagnosis can be made by a newborn screening test where they do blood work to test for immunoreactive trypsinogen or IRT levels. This is a pancreatic enzyme that is released when the pancreas is damaged. If it's greater than 60 ngs per ml, the test will be repeated a week later. If it's still elevated, a second test, called a sweat chloride test, will be ordered. This sweat chloride test is considered the gold standard for diagnosing cystic fibrosis. It measures the amount of chloride in the person's sweat by transdermally administering a solution called iontophoresis of pilocarpine to induce sweating. If the concentration is above 60 millimoles per liter, cystic fibrosis will be diagnosed.
Cystic fibrosis has a big impact on the respiratory system, which makes it important to do a thorough assessment and evaluation. To begin, you want to assess the history of the present illness and collect vital signs. Early manifestations to assess include wheezing respirations, fatigue, and a dry, productive cough. These manifestations will eventually lead to dyspnea, paroxysmal coughing with productive mucus, obstructive emphysema, and atelectasis. As the illness progresses, you need to assess for the appearance of barrel chest, cyanosis, clubbing in the fingers and toes, nasal polyps, hemoptysis, and the recurrence of bronchitis and bronchopneumonia, and also for signs of respiratory failure. We would assess for these findings through subjective and objective data in a thorough respiratory assessment. You want to start with inspection, looking at the skin and looking for any rashes or looking for any lesions. Then you're going to palpate for any masses, heaves, and checking for symmetrical chest expansion. Then moving to auscultation, comparing side to side, listening at the breath sounds, and listening for any adventitious sounds. To follow the progression of the illness, chest radiographs are commonly used, along with arterial blood gas tests, and also Brassfield score, which scores on the characteristics commonly found in cystic fibrosis exam. The first care plan that I'm going to go through is related to the diagnosis of ineffective airway clearance, related to thick mucus production and the inability to clear secretions. The goals of this diagnosis are to prevent, control, and minimize possible pulmonary complications, to improve ventilation, promote clearance of secretions, maintain adequate oxygenation, and carry out effective coughing techniques. Interventions for this diagnosis involve administration of inhaled bronchodilators to open the airways and decrease the inflammation. They are given before percussion and postural drainage. Inhaled hypertonic saline increases clearance and helps hydrate the respiratory tract. The administration of DNase enzyme replacement therapy, given via nebulizer, will thin mucus and make it easier for patients to cough. Along with those interventions, a physiotherapist will work with the patient and their caregiver to decide which techniques work best for them. Techniques of chest physiotherapy include percussion, vibration, and postural drainage. Chest physiotherapy techniques helps loosen the mucus and are typically performed 2 to 4 times per day. Postural drainage is usually done twice a day, in the morning and in the evening. Another intervention is positive expiratory pressure, which is a mask that builds up pressure in the lungs that helps bring the mucus up. High-frequency oscillatory devices are also helpful, which is a vest that is attached to a machine that vibrates at a high frequency that helps perform chest physiotherapy mechanically. There is also autogenic drainage, which is breathing techniques that require training. They involve large breaths out to release mucus. The final intervention is exercise, as it stimulates mucus excretion, and regular activity can slow the decline of pulmonary function. Most patients with cystic fibrosis can spend up to 2 hours a day doing chest physiotherapy and 1 hour a day receiving nebulizer medication. We will know if these interventions have been successful if the patient can perform coughing techniques and loosen mucus, also if they were able to maintain a patent airway. The second care plan is based around the diagnosis of risk for infection related to favorable bacterial growth environment due to stagnant mucus. Monitor temperature for signs of infection and do a sputum culture and sensitivity. The goals for this intervention are to minimize the risk of infection, suppress the growth of bacteria, and to have a normal white blood cell count, along with the treatment of current infective exacerbations. Interventions for this diagnosis include patients receiving all their necessary immunizations, including mumps, measles, rubella, varicella, pertussis, hepatitis B, and influenza. Another intervention is the administration of antibiotics or antimicrobials. It is important to monitor the levels so it does not lead to resistance, and examples of antibiotics could be gentamicin, tobramycin, and ticarcillin. The administration of NSAIDs or other antipyretics could also be useful. Another important intervention is infection control precautions, especially contact isolation. There are certain bacteria that do not affect healthy people, but they do have serious effects on patients with cystic fibrosis. Also, people with cystic fibrosis cannot come in close contacts with others with cystic fibrosis. They must remain 6 feet apart, and that is to not spread lung infections to each other. And the patient, healthcare providers, and anyone who will be coming in contact with them need to perform good hand hygiene. We will know if the interventions are successful if the patient remains free of infection and has a decreased cough and mucus production. Also, if their white blood cell counts are normal. There would be a deviation from the expected if the patient goes through a lung transplant, as there would be different medications and different interventions put in place. Another deviation from the expected involves patients with MRSA, as they require longer hospitalization and more antibiotic regimens.
Many people think that cystic fibrosis only affects the lungs, however it affects the GI system and the reproductive systems as well. I will be beginning with a care plan for the GI system. Beginning with assessment, you want to first assess past medical history. Have they had any hospitalizations? Are they having trouble with their medical regimen? What kind of medications are they on? Have they ever had intestinal obstructions, or constipation, or rectal prolapse, or gallstones? You also want to assess their current health history. Have they been vomiting? How many stools a day are they having, and what kind of stools are they? Are they bulky? Are they foul-smelling? You also want to see if they're having any trouble gaining weight, or if they're losing weight no matter what. If they're having any vitamin deficiencies, or how many pancreatic enzymes they have. Do they have a lot? Do they have a normal? Do they have none? You also want to assess if they're having any symptoms of anemia or diabetes mellitus, and go further and check if they have it. Check their blood tests over their A1Cs, their red blood cells. Check their blood glucose levels. You want to ask questions around, are they dehydrated? Are they in any pain? Do they have any stomach cramps? You also want to check if they're having any tissue wasting, or they're not growing, or they're having loss of appetite. And then you want to move to a focused abdominal assessment. So beginning with inspection, you want to check for ascites or abdominal distension. Are they guarding their stomach? Is there discoloration? You also want to see if they're really thin or if they look like they have a normal weight. And then you also want to auscultate. So you want to listen for those bowel sounds. Are they absent? Are they hypoactive? Are they hyperactive? Where are they? And then you want to palpate. You want to feel if they're in any pain or any rebound pain. You want to feel for masses or feel for an enlarged liver. And then you want to percuss. Are there areas that are dull that shouldn't be? What does it sound like? As for the diagnosis, they're at risk for unbalanced nutrition, less than the body requires, due to insufficient dietary intake or due to the improper digestion that's occurring. The plan for this individual is for them to have adequate nutrition, for them to stay physically active, for them to understand and stick to their medication regimen, and for them to reduce the risk for things such as bowel obstructions, prolapse rectum, and constipation. As for interventions, you want to provide pancreatic enzymes with meals and snacks within 30 minutes of eating. You also want to provide enterocotic medication to prevent neutralization in the stomach. You want a well-balanced, high-protein, high-caloric diet, and for younger infants, you can breastfeed and give enzymes. For older children, you want 3 meals a day with 3 snacks. And you want to provide vitamins A, D, E, and K with other probiotics and enzymes. You also want to prevent and treat GERD and diabetes, so give insulin and PPIs. You want to prevent constipation, so you give them stool softeners. You also want to create a feeding schedule and a medicine schedule and get your friends to help you with it. You also want to exercise and create a stool diary to track your stools. We will know that these interventions are working if the patient has an adequate BMI, if they are feeling knowledgeable, and if they are able to cope with their extensive schedule, if they're feeling well and hydrated, if they're gaining weight or gaining muscle mass, if they aren't experiencing complications, and they have a normal blood glucose level and normal electrolytes, and there isn't any problems with their liver, and they're not having any issues with GERD anymore, if they're growing adequately. As for the fertility care plan, we begin with assessment. We want to ask questions surrounding if they're having trouble conceiving, or what's their family history like. If they're male, what are their sperm specimens like? Are they sterile? Do they have a low sperm count? As for females, we want to ask questions around their menarche. Was there late onset or irregularities? And we want to do a physical exam of their cervix to check their cervical mucus. Is it thick? Is it thin? We also want to check if there's developmental delays, or if they're having psychological distress, or having issues with coping, and we want to check what their relationship status is like. For the nursing diagnosis, the patient is at risk for low self-esteem and anxiety related to infertility, and the overall plan is to help them understand and cope effectively with the fact that they may not be able to have a child, and for males, effectively coping with possibly being sterile, and for females, the risks of becoming pregnant and how to reduce the risk, and also understanding that cystic fibrosis is a hereditary disorder. Interventions include genetic counseling, psychosocial counseling, IVF therapy, educating the patient on the risk of pregnancy and the risk that their child may have cystic fibrosis, examining sperm specimens, talking with partners, and getting lots and lots of support from family members and from friends. We will know that the interventions have worked if the patient understands why cystic fibrosis causes infertility, if they're feeling more relaxed and less anxious, if they understand the risk factors associated with pregnancy, and if they're making steps towards seeing a counselor or a specialist. Deviation from the plan may occur if the patient still fails to gain weight. They may need a gastrostomy tube, which comes with skincare and a whole other plan. As for fertility, the patient may become pregnant and need a whole new plan around prenatal care.
Cystic fibrosis impacts everyone involved in the care of the individual. It is more than a sole effort, it is a family disease. Looking at the client who is diagnosed with cystic fibrosis, we have to understand that they are going to come across a lot of difficulties within their quality of life, their daily living activities, and anything that happens while they're a child, into an adolescent, and into an adult, as the life expectancy for people diagnosed with cystic fibrosis is continuing to increase. We must first look at how they might struggle to understand what's really going on, especially depending on what age they're diagnosed. It can make it difficult for parents as they must basically enforce this treatment regimen that they're being told will help their child, but the child isn't really fully understanding and they just want to be a kid. Kids want to do what they want when they want. And this comes from birthday parties. They can't just randomly go to a birthday party one day. They have doctor's appointments and treatments that they need to follow. This also happens with adolescents, but we can give them kind of more independence by letting them know when their treatments are and their doctor's appointments and letting them work their plans around those times. But when it comes to adulthood, it's almost like cystic fibrosis is incorporated into their daily lives. They only really have difficulty when it comes to them thinking about starting a family, with, like Sophia said, regarding infertility and also passing on the cystic fibrosis gene to their children. It can cause some anger and disagreements with their partners and further cause headaches and stress, as they might want a family, but there's a lot of worry surrounding it. When looking at cystic fibrosis on caregivers, we must first discuss their feelings when it comes to diagnosis of their child. They can feel a lot of guilt, and it can also put them on edge because they feel their child is vulnerable and they don't want to harm them anymore, causing them to change their parenting behaviors to make sure the child is as safe as possible. This can also be important because they're the ones that are making the routine treatment be adhered to at all possible. In the long run, they express hope for their child to be able to have a normal life and to be able to do everything that they want the child to do. With a chronic illness, we cannot forget the impact that the siblings experience when a family member has been diagnosed with cystic fibrosis. A lot of siblings experience this feeling of resentment towards the family member with cystic fibrosis because they're being treated differently by their family. For example, through discipline and tolerance that their parents are giving them towards activities. They also have to take care of their family member that is sick when their parents are juggling a lot of stuff or trying to get stuff ready, and they have trouble discussing these feelings with their parents because they don't want to put more on their plate. It's also shown that siblings can show feelings of empathy and maturity as they see what their family member who has CF is going through on a daily basis. And siblings also struggle during their adulthood as they fear that they can give the CF gene to their children themselves. With cystic fibrosis, the biggest social determinant of health is finances, as there are many treatments that must be provided, like supplements, dietary restrictions, medications, specialty machines, transportation, and of course hospital stays. Luckily, Cystic Fibrosis Canada offers financial resources to assist with this burden. Another social determinant of health that is important is education. Without proper education, it can make the journey with cystic fibrosis 10 times more difficult. But we also must ensure that the education is to the patient's and family's literary level. Geographical area is important to mention as it can become increasingly difficult for families that live in rural areas or in adjacent provinces that need to visit doctors within Nova Scotia, or for hospital stays when the CF gets worse. An important resource to mention is Cystic Fibrosis Canada. I mentioned it earlier regarding the social determinants of health. They can provide resources to the families, for example, the Stephen Russell Memorial Fund, which assists with medical supplies. It's important to note that they do have buildings and places in each individual province. Other resources to mention are social workers, counselors, respite care for parents, and online communities where the clients that have been diagnosed with cystic fibrosis and the parents can go to discuss their illness, their emotions, their identity, and relationships. It allows them to be able to have a safe space to fully understand what's going on, to talk about their story, to listen to other stories, ask questions. Thank you for listening to our TED Talk. I hope you enjoyed and learned a bunch of information about cystic fibrosis.